Okay, thanks everyone. Welcome to our virtual RHP7 stakeholder update. I appreciate you being here. And thanks for joining us as we discuss what's going on with the DSRIP program right now, in particular in light of the coronavirus pandemic and what effect that's having on DSRIP efforts in our region and to some extent across the state as well. Sandy, if you could move to the next slide. We will start out with some housekeeping. If anyone is having trouble connecting, I realize if you're hearing me, you may not be, but if you're trying to connect by video and are only able to call in by the phone, you can text or call Sandy at Sandy Co-Simmons at Central Health at 512-507-3082. Or if you have colleagues that are having trouble connecting, she can give you some assistance there. Just be aware, we are recording today's webinar, and the slides from the webinar today, as well as the recording, will be available on our website, texasrhp7.org, after today's event. Please sign in. If you are connected by video and are able to use the chat function, please write your name and organization into the chat feature so we can have a record of who attended. If you're joining only by phone, if you would, please send me an email at katie.coburn@centralhealth.net to let me know you're here. We are going to be taking questions and having discussion at the end of our time together. We will, and feel free to type questions into the chat during the presentations. So if you want to make a note of a question you have, that's fine. We won't address them till the question and answer period first. We're going to take those all at the same time at the end, but feel free to do that if you'd like. Okay, from there, let's get going. Next slide, please. So our agenda today is a DSRIP program update with sort of a policy and funding overview from the RHP anchor perspective, Central Health, so our regional perspective. Then, as we've done at other stakeholder events in the past, we will hear from a panel of DSRIP providers to have them each have a few minutes to describe their DSRIP activities and the impact of COVID-19 on their work. And then finally, we'll open up for discussion. So let's get going. Next slide, please. So a brief recap to catch us up to the present day. The DSRIP program, as I'm sure many of you know, began way back now in 2011 with the Federal Center for Medicare and Medicaid Services, which I'll refer to as CMS, approval of the Texas 1115 Medicaid Transformation Waiver. The overall waiver authorized $29 billion in supplemental Medicaid payments to Texas providers over that first 5 years. $12 billion of that was directed to the DSRIP program, with and RHP7 providers during that time earned over $800 million in incentive payments during that first phase of the waiver. The DSRIP is a locally driven, it's based on community needs, and as an incentive payment program, it offers the flexibility to providers to innovate, to deliver better care and improve health outcomes, and also deliver services not traditionally billable to insurance, but that can improve health. Major DSRIP focus areas in our region are behavioral health, primary care, patient navigation and care coordination, care transitions, especially for complex populations, chronic care management, and health promotion and disease prevention. So that was the first phase of the program, which was the first 5 years plus a one-year extension. And then the waiver was renewed in 2018. And it shifted the strategic approach of the program from one where providers were implementing delivery transformation projects to work focused on system-level outcome improvements. So when the waiver was renewed, DSRIP program was reauthorized for 4 more years. In those first 2 years, which we call DY7 and DY8, we've already passed. In each of those years, $176 million in DSRIP funding was available to RHP7 providers. In DY7, they earned about $172 million. in incentive payments. And in DY8, they've earned $140 million to date, although there's still time to continue earning those funds to report some delayed metrics and carry forward items. So we expect this number will increase as we move through the full reporting and payment process. So in that renewal, we are now in DY9, or fiscal year 2020. You can see that with the red star. We are here in those final days. Again, we're continuing with district system level outcome improvements, but the overall funding levels in these final 2 years of the district program are decreasing, about 6% in DY9, an additional 14% in DY10. So providers right now, as you can see by the red circle, are working toward a regional incentive amount of about $165 million. But as we all know, the coronavirus pandemic hit in the spring of 2020 and has significantly shifted what district providers can do to earn funds and how they're approaching their work in these strange times. So we will talk about that here a little bit more in a minute. Next slide, please. So where are we headed? Even though we're in the middle of a pandemic officially, nothing has changed as far as what's next for the district program. The overall 1115 waiver ends on September 30th, 2022. The district program is still scheduled to end in September of 2021. And so many people, stakeholders and providers alike, have a lot of questions about, well, what happens next? What do we do after DSRIP goes away? And as part of the renewal terms and conditions, CMS required HHSC to develop a transition plan. And the plan is intended to further develop delivery system transformation efforts without DSRIP funding. And once you have access to these slides, you can see that there's a link to it right here. The plan is up on HHSC's website. The plan is really essentially a series of reports that are analyzing DSRIP results and potentially proposing new ideas for strategies to continue transformation efforts past the end of the DSRIP program. Two key ones for DSRIP. The reports are due over the next couple of years. Two key ones are, there's a report due on September 30th of this year that may propose new transformation activities or programs that could occur during the final year of the waiver, so DY11. And additionally, another report is due to CMS, due in September of 2021, that will propose transformation programs that would begin under the authority of a newly negotiated waiver at some point after September of 22. So HHSC is currently working on the analysis that will inform these reports, but they haven't shared any specific proposals yet about what they might propose to CMS. And also in response to the coronavirus pandemic, CMS has offered that HHSC delay the timelines on some of its reports, which HHSC is currently exploring. And so we don't really know right now what impact this may have on the development of those continued proposals. Next slide, please. So let's talk about COVID-19's impact on DSRIP. I mean, obviously, we all know very well that the environment for the entire healthcare system, including DSRIP, has been turned on its head. And much of DSRIP's incentives are geared toward managing chronic disease, getting people the preventive care they need to stay healthy. And that's pretty difficult to do when providers are prevented essentially from all but emergency visits to clear capacity for COVID care. So it's leaving providers unable to meet their target patient numbers to make sure they're providing a consistent level of service to the Medicaid and low-income uninsured population, and also really hindering their ability to achieve their population outcome targets. And without achieving these targets, there's no way to earn the incentive payments that providers rely on. So, you know, as you can imagine, disease management and immunizations may take a back seat to acute care for COVID right now. At the same time, staff working towards DSRIP outcomes and were often redeployed to COVID-19 response, further depleting resources intended to achieve outcomes and gain incentive payments. To some extent, these services were redirected to telehealth delivery, which really has been good at mitigating a lot of access concerns where that makes sense for both the service and the population being served and the provider. But in the DSRIP specific world, another particular challenge is that many metrics require a face-to-face visit for the work to be counted towards your outcomes. So it's obviously a real challenge that everyone's facing. CMS and HHSC are negotiating different ways that providers could earn funds in this year that's been impacted by COVID. CMS and HHSC we're also experiencing the same types of reprioritization and staff redeployment that providers were. So they've been negotiating ways to earn funds. Most providers will probably be able to earn their DY9 performance funds at the same level as how they performed in DY8. But where that is disadvantageous, they're working on other ways providers might be able to earn funds. So I think their goal ultimately is that they want to keep the funds flowing and be aware that COVID has really turned things on its head. We hope those negotiations and rules will be finalized within the next few months. So meanwhile, that's what's happening kind of at the CMS and HHSC level and with providers. Provider associations are also working on mitigation strategies for the impact of COVID and using DSRIP as a potential tool to help that. Right now, provider groups such as the Texas Hospital Association, Teaching Hospitals of Texas, Community Mental Health Centers, they're advocating with HHSC and with state government to ask that the state request an extra year of DSRIP funding. So that would continue the availability of the DSRIP pool all the way through September of 2022, rather than ending it in September 21 as it's currently planned. That request is in the early stages, but the state hasn't made any formal request to CMS about this, but just letting you know, this is one of those options that are out there that people are trying to put forward as a way to mitigate the financial impact on health providers in the pandemic. So, next slide, please. From there, that's an overview of where we are with the DSRIP program level statewide. Definitely, if you have questions, feel free to note them in the chat. We'll address them during the discussion period. What I'd like to do now is turn it over to hear directly from our regional providers. As you likely remember, we have 7 official members of our RHP here in Central Texas, along with 2 grandfathered members that are now officially in other RHPs but are still join us. Our 3 hospital systems are Ascension Seton, with Dell Seton at UT and Dell Children's participating as performing providers here, St. David's Healthcare, and also Christus Santa Rosa Hospital at San Marcos, formerly Central Texas Medical Center. So there are hospital systems here. Our 2 mental health centers participating today are Integral Care here in Travis County and Bluebonnet Trails Community Services, serving the rural counties outside of Travis. We also have our Community Care Collaborative Organization, a community-based care partnership between Central Health and Seton. And finally, our local health department, Austin Public Health, with the City of Austin. So we'll go ahead and get started with our panel. Sandy, if you would mind we'll take the presentation down for now. Thank you. And we will move to, first off, Megan Nadalski of Bluebonnet Trails Community Services. Megan?
Hi, Katie, can you hear me?
Yes, I can hear you.
Okay, great. Thank you, Katie, and I'm going to try to be brief. The anchors have kindly provided us a couple of topics that they'd like us to cover, so I'm going to roll through those, and I am hoping to hit right at 5 minutes. So Katie, just shut me off if I get past 5. Thank you everyone for joining us today. My name is Megan Nadalski. I'm our Quality Management Director, as well as the 1115 Medicaid Waiver Director for Bluebonnet Trails Community Services. As Katie mentioned, we're a community mental health center in an RHP7. We serve Bastrop, Caldwell, Fayette, and Lee. We also serve several other counties in different RHPs, but those are the counties that we're joining with today. So to start off, she wanted us to mention a couple of highlights, highlight some successes that we've recently had in DY8 or since DY8. And one of the things when I was thinking about this, I have our metric numbers, all of the outcomes that we've achieved and individuals we've been able to serve. But the thing I really wanted to focus on here was the foundation that allowed us to do that. In the last couple of years, we've been focusing on building that foundation of continuous quality improvement and what that looks like as we transition to a system of care level intervention for all of these outcome measures. And really being able to use that CQI foundation with a data-driven, comprehensive approach, yet using commonsensical interventions to really improve those outcomes was a large success for us and was demonstrated by the achievement of our outcome measures in DY8 or PY2, I know, or no, I'm sorry, PY2, goodness, PY8, no, PY2 for outcome measures, I'm sorry, so many PY/DYs in our last performance period. So that was a really strong success for us that allowed us to continue and sustain that success as we moved into this challenging time. The next piece here are the organizational changes that we've made due to COVID-19 or the pandemic. And the biggest thing that I wanted to focus on here was communication. As we're not able to anymore just walk down the hall and talk to our colleagues or have team meetings in person, we've really needed to be creative in the ways that we're communicating. And our agency has implemented several things that we've had to change here. So we developed a COVID leadership executive team, which has a lot of our executive management members, as well as our IS department, our communications department, to ensure that we are meeting on a daily basis to stay on top of all of the changes. We also developed a healthy response email, and this is the way our management team is communicating now out to all staff. So every day they get something from our team that's either about an update for COVID-related items. It could be something around chair yoga, wellness, engagement for individuals on televideo or telephonic services. We developed a series of webinars where our executive team members also are communicating to all staff, where they have the opportunity to log in and hear from team members on FAQs for COVID-19, on engagement, on how does this look from the HR perspective, et cetera. We've implemented a new text messaging campaign to the individuals and services. As you all know, sometimes the rules that we're following or the guidelines change in the middle of the day, and we need to get that information out to our individuals and services. So we have rolled out a text campaign to make sure we're communicating to the individuals and services. Of course, we're updating all of our signage in new fun ways and trying to make sure those are eye-catching so people can see the important information as they approach any of our buildings. And then we're trying to leverage all possible avenues through social media. So communication, as it's always a foundation of the important work that we do, this has caused us to be creative and think outside of the box to address that challenge during the pandemic. Moving right into challenges, of course, balancing the need and the want to serve individuals while adhering to safety protocols and regulations, as well as making sure that we're keeping our staff safe and the community safe. As Katie mentioned, we have metrics that we need to achieve to serve incentive payments, but we really need to make sure we're going back to the heart of why we're doing this and serving those individuals there. So we've remained open during this entire time, and we really had to utilize creative strategies to continue to connect individuals to those critical services during this time. And of course, staying on top of those daily COVID challenges requires a lot of staff resources. It also requires our teams to be really nimble. At times, as I mentioned, we have to make changes in the middle of the day that can impact our entire system. So That has been a challenge moving forward that I've been proud to be a member of that team to help facilitate those changes. The only thing that doesn't change is change itself, right? So the next piece there is planning for the future. So what are we going to do? And it's difficult right now to plan for the future. But over the last 5 months, we've really been working hard to diligently continue to develop our system of care from the lessons learned that we've mentioned above during the pandemic to put us in a good position to be there for the community on the other side of this, as well as throughout it. So to that end, we've partnered with Texas A&M College of Nursing to add medical services to our crisis respite unit, outpatient clinics, and ISD settings. We were awarded a 3-year HRSA grant alongside of Texas A&M College of Nursing, adding integrated healthcare in Fayette, Lee, and Williamson counties. In partnership with our local psychiatric hospital, we've also expanded the number of beds in our extended observation unit from 12 to 22, which is a pretty large jump. This extended observation unit is embedded in Georgetown Behavioral Health Institute and serves the residents of Bastrop, Caldwell, Fayette, and Lee counties, as well as Williamson counties. We've also pitched and were awarded a 3-year contract to develop a transitional living home model in Williamson County, staffed to effectively support the discharge of individuals from a state hospital. So we're really looking to utilize those lessons learned and use this time to establish those new opportunities for us to move forward and be there for the community. Lastly, they wanted us to say, what do you want the community to understand about our work during this time? And a couple things from me. I'd like everyone to know we're still open. It may look a little different, but we're still here. Our doors are still open for the most part. We're still serving people, and we're committed to doing that. We also are recognizing and celebrating what we've learned during this time, and we're fortunate to recognize and be able to really see those strong leaders that have emerged during this time that are able to strengthen our care. So we are well prepared to take on this extraordinary new challenge in the midst of the pandemic. And lastly, I wanted to just say thank you to everyone for being part of this collaborative. Having time to get together and share these opportunities is essential. And by working together, I think we're going to be able to continue to provide that level of support to the community as it's needed, pandemic or not. So thank you, Katie. That's us for Bluebonnet.
Thanks, Megan. I appreciate you and all your hard work. Let's turn now to Ann Burkhammer Miller with Christus Santa Rosa and San Marcos. Ann, if you're there, we can't hear you.
Can you hear me now?
I can hear you now. Thank you.
Great. Thanks, Katie. My name is Ann Burkhammer Miller, and I'm the Revenue Cycle Director and 1115 Waiver Coordinator at Christus Santa Rosa Hospital San Marcos, formerly known as Central Texas Medical Center. The Christus Health System purchased Central Texas Medical Center from the Advent Health System in April of this year. Under DSHRP, our focus is on diabetes care for patients receiving services at our community-based primary care clinics. The metrics used to determine success in managing this chronic disease is improvement in A1C test results, blood pressure, and assurance that all patients receive an annual foot exam. In 2019, we implemented a chronic care management program, and under this program, an RN case manager provides telephonic outreach to enroll patients to help them adhere to the physician-directed plan of care. And this is done by providing education to patients, promoting self-management in such areas as medication administration, diet, weight management, and the importance of glucose and blood pressure monitoring. During DY8, we maintained a chronic care monthly caseload of approximately 40 patients, and we enrolled about 8 new patients every month. We fully achieved our foot exam metric, but fell just a bit short on the blood pressure and the A1C metrics. While we did not fully achieve 2 of the 3 metrics, we were pleased with the consistent enrollment in our chronic care management program. The physicians actively refer patients to the program. That's been a big success. For them, it's difficult to evaluate, treat, and educate patients within tightly scheduled appointments, so this program is valued by our medical providers. During DY8, one of our most satisfying accomplishments was adding a second provider to our community clinic, which primarily serves the MLIU population. This has significantly improved access and accommodates patients needing post-discharge care after hospitalization. There's no question that the COVID pandemic has significantly disrupted clinic operations. During the month of April, patient encounters fell 39% from our pre-COVID monthly average. We saw a slight rebound in May, but we still realized a 22% reduction in overall visits. And this was mainly due to patients adhering to the stay-home mandate and was especially true of patients with underlying health conditions such as diabetes, so regular preventative care visits continue to be compromised. Additionally, we had staff and physicians unable to work due to illness or self-quarantine reasons, which really limited clinic capacity. Managing patients that do come to the clinic is challenging, as sick and well patients must be routed to separate sections of the clinic, which spread staffing resources. From April through July, our clinics provided over 2,400 COVID tests, and these were mainly to patients on a walk-in basis. This caused redeployment of some staff from direct patient care due to consumer demand for COVID testing. So even with a reduction in patient visits, we still struggle with adequate staffing resources. During April and May, telehealth attributed to over 60% of our visits. Beginning in June, we slightly reduced this percentage in favor of in-clinic care, but we still rely on telehealth for high and moderate risk patients. While telehealth is a safer alternative, evaluation and treatment of patients is not always optimal, as it does not support diagnostic testing such as A1C and blood pressure monitoring, and Katie alluded to that in the introduction. Some patients are able to self-report blood pressure and provide a subjective report on something like a foot exam as an example, but that's not always deemed as reliable. Our community clinic, which again predominantly cares for our MLIU population, has a lower telehealth rate, either because patients don't have the resources to support telehealth participation, or the physician feels it's important that certain patients receive in-clinic care. But either way, this clinic has also experienced a reduction in preventative care visits. While it's too early to predict, we believe COVID will have a negative impact on our DY9 district metric achievement for many of the reasons already cited. The severity of the impact will really depend on the continued prevalence of COVID cases and the positivity rate. We have experienced a similar trend within the hospital via reduction of elective surgeries, diagnostic services, and overall emergency room visits. So again, we think that may impact our Category B MLIU measure. Depending on financial resources, we would like to continue our chronic care management program and potentially expand services for other chronic health conditions. Both patients and physicians have responded positively to this program and believe that has helped us with overall metric achievement. Participation in DSRIP has enhanced our ability to focus on our organizational mission, which is to provide quality and accessible care to all patients, specifically supporting our ability to bring additional healthcare resources to the MLIU population. In closing, we would like the community to be aware that we are strengthening our provider network in San Marcos and the surrounding communities in order to increase access to care close to home, especially for specialty care. We are also focusing on IT interconnectivity between our clinics and system facilities in order to provide more efficient and coordinated care. These will be key goals for the remainder of calendar year 2020. Thanks so much.
Thanks, Anne. Appreciate that overview, and those COVID impact numbers are just eye-popping.
They're staggering, really.
They are. Let's move now to Catherine Cantrell from Austin Public Health. Catherine?
Hello.
Hi.
As Katie said, my name is Catherine Cantrell. I work for Austin Public Health, the Austin Local Health Department. I am the district program manager for all of the programs that run under the department. And it is quite a time to work at a local health department this year. But first, I'm going to talk just a little bit about some of the 2019 successes that we had that really are still kind of contributing to the work that we're doing today. And one of the major successes we've had in 2019 was the solid internal systems that our department was able to develop. We transitioned to a new EHR system, and if anybody's transitioned to a new EHR, you know what we're going through. But it really kind of identified some silos in our delivery systems, gaps in our data collection. So we've been working hard and have accomplished a lot of standardizing of collection of data and entering of data. This type of analyzing of data is really nothing the department has done as a whole before, individual programs maybe, but overall. And the impact is that we're having new data that is really critical to planning and development of our programs, and really seeing how these district funds and how our services are impacting the community directly. We, as Austin Public Health, are very heavily involved in the local response to COVID-19. We've activated and mobilized our emergency preparedness plans for the pandemic, and the department is really serving as disease experts right now. We have very talented medical staff and epidemiologists that work for Austin Public Health. And we've set up contact tracing. We're enforcing types of quarantine protocols. We are setting up mass clinics. And not just in our COVID response, but we also need to continue services, especially for vulnerable populations and vulnerable to COVID-19. They're life-sustaining resources that these people need. So we're talking housing and food and mental health services. So we have shifted most of our programmatic priorities to the COVID-19 response, and including, like we said, I mean, a large amount of staff is going over to the COVID-19 response, doing contact tracing, data processing, working our point of testing site, specimen transportation if needed, et cetera. So we do anticipate this impacting our district performance measures. We haven't really talked about it on a department level much. I've mostly done survey with directly with program and program managers. And the common consensus is that the number of encounters and type of encounters is going to be different than previous demonstration years. And on the flip side, once our services completely resume, we will likely see an increase in morbidity of our clients because of lack of services, lack of ability to get to services, being on quarantine. So we are anticipating an increase in service delivery potentially. And on top of COVID and continuing our services, there is the inevitable distrip end. So APH is seeking other funding opportunities. Specifically, that will continue to serve the Medicaid low-income and uninsured populations. We are also internally doing a lot of cost-benefit analysis on where district funds have had the most impact in our department. We're currently doing a cost-benefit analysis on how district funds have impacted the department as a whole, but we've broken it down into programs and services that have actually received district funds to see what the impact of that has been. And so moving forward as a department, we can continue our efforts on and continue placing funds where impact has been the greatest. Another thing is APH is really good about forecasting out district payments and coming in under budget most years. So we will have remaining funds beyond district's end to sustain some of our programs and projects. And lastly, the community, what do we want the community to understand about us? Our organization, just like most health departments, is designed for care on a community level that is really sustainable, that is reliable and supportive. And there are services that are provided on a daily basis that people depend on for their livelihood. We're talking food pantries, diabetes screenings, HIV tests, breastfeeding evaluations and education, housing support, creating policy for the community's well-being. So what I want the community to know most about and understand about our work is that the department and this concept of the power of public health. Local public health departments are really rising to this challenge of COVID-19, and we are continuing to focus on these essential health services for people who are really vulnerable during the pandemic. And one category of essential worker that is just shining right now are those that are working on the front lines in local health departments. The power of public health is really on display, and we'll continue providing these services and being innovative in our delivery as long as it's needed. Thank you.
Thanks so much, Catherine. Really appreciate that update and really appreciate what you and all your colleagues are doing at the health department right now. It's a huge lift, and we really rely on you guys. And so thank you from the bottom of our heart.
We're honored. Thank you so much. Yeah, thank you.
All right. Let's move now to Rachel Hardegree with the Community Care Collaborative. Rachel?
Okay, great. Can you hear me, Katie? Great. All right, thank you. My name is Rachel Hardegree. I'm a district project manager with the Community Care Collaborative. And the Community Care Collaborative, or CCC for short, contracts with providers to deliver care to the low-income uninsured population. And our specific focus areas are centered around 7 metric bundles for the district work, and that includes 36 total measures. And so what that really kind of looks like is focusing on diabetes care, primary care, cancer screening, adult dental care, hospice care, behavioral health, and non-malignant pain management. And so to highlight some of our successes for DY8 and accomplishments, that's really attributed to our contracted providers who've established innovative and new ways to kind of track patients and where they are in their care, and also how they've established and refined dashboards over time to really kind of provide that data-informed or data-based care moving forward to identify gaps for patients. Our providers have also developed pre-visit reminder systems to help inform those care at those visits, where patients don't have to come back for multiple visits to address all of their primary care needs. We have also achieved 100% metric achievement for 29 of the 36 measures for which we are participating in. And I think that's a huge accomplishment, and huge kudos go to our, again, our contracted providers who have worked so hard and diligently over the past year or two on this work. And in terms of how our organization has responded to COVID-19 and the pandemic, our providers have really, what you've heard earlier today from our colleagues here on this call, the shifting of resources and redeployment of those resources and staffing has really impacted service delivery. There's been multiple service delivery interruptions with our clinics, participating providers, their clinics having to close and then reopening and shifting and having morning or afternoon sessions in order to allow time for disinfection and cleaning and special protocols in order to maintain safety. Also, our clinics have implemented drive-through testing and looking forward to, currently in the planning process for future vaccine delivery and administration, trying to think through, okay, next steps while we're also in the process of addressing the current pandemic. I will say, and I believe Anne probably mentioned this earlier, and probably Megan too, but the highlight or silver lining I would consider would be some of the shifts into implementing telephonic or telemedicine visits. Previously, some providers have felt like, oh, this is a big, heavy lift, this is difficult, patients won't go for it, those types of things. And I think that has really been a surprising positive aspect of this pandemic, is that it's kind of opened some doors. It's forced us to kind of move and step through those doors of the telemedicine work moving forward. So more to come there. In terms of challenges, our contracted providers had established those kind of pre-existing templates and dashboards and resources in the clinic setting with specific care teams to address, comprehensively address the needs of our patients. And because of those redeployment efforts and resource shifting, that's kind of taken a little bit of not a back burner, but it's taken a little bit of a shift in operations there for our contracted providers, which has been a little bit of a struggle. And so one of the last things we wanted to talk about today, how are you approaching planning for the future? I echo, again, our colleagues here, very difficult right now in the midst of the pandemic response with things changing. It seems like daily, and having to shift and pivot and in respect to addressing the current needs, emergent needs. So we're moving toward, again, what I mentioned before, ways to deliver a vaccine in the future. So we're kind of working in that direction. However, we are committed in the meantime to providing the best
care possible to our population in the midst of this disease and even on the other side once the pandemic has subsided. And what do we want the community most to understand about the work now is that we're really keeping a close eye on COVID cases and making sure that resources and information is available for our patient population as to how they can protect themselves appropriately, specifically among our Latino population, which currently has substantially higher rates. And so that's really what we're focused on at this time, is just kind of making sure that the vulnerable population that we serve, our target population, is receiving that information and resources as needed. And we're just kind of keeping an ear to the ground and being as responsive as possible to address those needs. And with that, I'll close.
Thanks very much, Rachel. I really appreciate that. I'm getting ready. Let me hand it over next to Matthew Frells from Ascension Seton. He's going to present for both Dell Seton at UT and Dell Children's. Matthew? Hi.
Hello. Hi. My name is Matthew Frells. I'm the Process Improvement Specialist for Ascension Medical Group, which is our ambulatory space at Ascension. We cover, so just a little background real quick on the medical group, we cover about 19,000 square miles from Waco all the way down to San Marcos. So we have a very large footprint overall, though for our district program, we really only focused on about 3 clinics in the entire network. Really focused on our primary care clinics that serve that milieu population that we have, which was our Trinity and McCarthy clinics. So back in late October, we were probably only achieving about 45% of our metrics. We had about 27 different measures we were tracking. And we really partnered with the clinical operations team, because I'm on the quality team, sorry, I didn't say that. We really partnered with the operations team and really started to work with them to figure out how we can meet these measures and achieve success. And we were able to bring in some patient navigators and nurse navigators, something the medical group had never had before in the past, to really help close these gaps. It really brought the focus away from the quality team as disrupt being a quality thing that y'all need to focus on, to the clinic to say this is an operations program that the clinic should be focused on, the clinic should help with, and it's not just quality forcing this on you. This is something, this is how the clinic should operate. So it was a really, in my head, that was one of our key successes for last year, was really getting the operations team to understand that it's not just disrupt on the quality side, it's disrupt for the entire clinic. So we were marching right along, doing great, and then boom, March came along, COVID hit. So being a very large medical system in Austin, we did shut down our clinics come middle of March. So most of our primary care clinics closed. Our resources really got redeployed out into the field to help with the COVID response. We were scrambling to open COVID testing, drive-through testing. We were opening clinical triage clinics. We really wanted to be able to help take the pressure off of the ER. So we were racking our brains. Our primary care lead, Dr. Perez, was really focused on how do we get these resources and help keep people out of the ER, keep them in the clinic, and how do we do that? Well, what that did is that pulled the resources away from our district program, because those same resources were our primary care folks. And so it really kind of led us to have to put district on hold. We just didn't have a choice. We didn't have the manpower out there in the world now to be able to open these brand new clinics, run these drive-through tests, and focus there. But to echo what Rachel had talked about a little bit, was what that did is it kind of opened telehealth. Now suddenly, where providers, like she said, providers weren't interested. They're like, no, this is not, I can't do this. Now, wait, I have to do this because there's nothing else. And so our CO is very fond of a graph he likes to show, but it's our in-person visits just plummeted. They dropped to about 20% of their pre-COVID volumes. But our telehealth jumped back up to kind of compensate for that. And so while we weren't able to do those in-person visits, we were still able to do those telehealth visits to help meet all the critical needs of the patient. If they needed to have meds refilled, if they needed to be seen, we could make that diagnosis over the telehealth. And what that allowed us to do is kind of help separate out the population and helped us really reopen our clinics to say, okay, we have our COVID testing clinics over here. If a patient is COVID positive, they go over here. If they're not, they can go back to our regular primary care clinic. And so then we were able to see our patients who had diabetes, our patients who had those chronic heart conditions, and get them the help they need for that preventative care, which was kind of cut off mid-March. And so really with the response there, we opened the clinics, we had the drive-through testing, we looked at the huddles and everything to get that communication flowing. And it was really just kind of, how do we meet this challenge head on? So others outside of the resource drain, which was kind of expected across the board, lately what we've been doing is, now that it's kind of started to die down, we're starting to refocus back into the clinics. So really, as we're planning for the future, we're really focused on how do we open our clinics safely? How do we open them so they are socially distant? We have all the COVID processes in place, not just for our primary care, but Ascension is very specialty heavy. So we have the majority of the cardiologists, the majority of the endocrinologists. A lot of that is what our main primary focus is. So how do we do it across the board, not just for primary care? And so we're really looking at how do we continue with our telehealth presence. Patients seem to really like that as a method of not having to leave their house, not to be safe. How do we continue to reopen our clinics safely? And really, how do we continue with our nurse navigation piece that we started with COVID? That was a great success for us, for our primary care clinics. How do we really expand that out? How do we keep that growing until we can cover all of our specialties, all of our primary care? And really looking at the future and how we're going to grow the system as a whole to be able to support everyone as we move forward. And then lastly, the one thing with the community to know about us, really, it's as we look at how we're changing medicine. Disrupt was designed to change the way we fundamentally think about medicine, in my opinion. It's no longer just focusing on a problem, it's focusing on all of your preventative health. We're asking the providers to look at all of these things because they're all important. It's not just the one thing I came in to talk to you about today, it's everything that's important. So as I look at the clinics, I see them starting to fundamentally change the way they look at their approach to medicine. Like I said, Dr. Perez is a fantastic leader in our primary care space, and she is behind this 100% because she looks at holistically a patient and not just one thing at a time. So, and I believe that's what Disrupt is really intended to do, is to motivate us to really change our approach. And as we move forward as Ascension, we're really looking at how we can do that across the board in all our specialties, not just primary care. Because we need our cardiologists to ask if they've had their colorectal cancer screening or their breast cancer screening. They may not do it, but we need them to ask. So we're looking how we can roll this out across the board and really get this implemented and get that fundamental change across all of Ascension. Okay, thank you.
Thank you, Matthew. I appreciate it. I lost track of my mouse there for a second, but I appreciate that overview from you. We have two more speakers in our panel, and next we'd like to hear from Brittany Alderman at Integral Care. Brittany?
Thank you, Katie. I'm Brittany Alderman, and I'm the Population Health Administrator at Integral Care. So I'm part of the team that oversees our 1115 waiver measures and initiatives, and I've been working on the waiver team for about 2 years now. Integral Care is a local mental health authority for Austin, Travis County, Texas. We serve about 30,000 people each year with mental illness, substance use disorder, and intellectual and developmental disabilities. Right now, we have about 21 pay-for-performance measures with the 1115 waiver. And since moving to this transition to provider level reporting, we've achieved 100% of our metrics each year. So some of the DY8 successes and accomplishments, one of the biggest challenges and accomplishments was navigating the transition to a new agency-wide EHR. I've heard that a couple other centers have been dealing with that this year, and it's been a challenge, but also it allowed us to do a deeper dive into all of our different measures. We transitioned from Cerner to NetSmart, and so as we moved into this new EHR, we began building all 21 of our measures again from scratch. But we've done extensive QA, and I think we're finally at a point where we really can kind of trust and validate the data that we have. We also launched new initiatives in chronic disease management and substance use. So we launched a recovery navigation services team to help coordinate referrals to residential treatment, sober living, medication-assisted treatment, and other facilities in the community. We also launched a health promotion team to enhance access to specialty and primary care services. It's a team that's comprised of RNs and QMHP level medical care coordinators, and they assist with addressing gaps in lab screenings, follow-up after hospitalization, and other primary care services. We also used our 1115 waiver data to serve as a stepping stone and move more into the population health methodology. So we're now performing risk stratification and analysis based on different high-risk health indicators, demographic information, and then we use that data to inform our clinicians when they're doing care planning, preparation, and treatment. So how we responded to COVID-19. Well, first of all, our teams quickly adapted most of our care to telehealth. So whether it was clinic, community-based, or school-based services, we moved that into telehealth and televideo. For our adult services, we moved everything into one location at our East 2nd Street service location. We also distributed hundreds of flip phones with unlimited minutes and tablets to clients to help them access our services virtually. We also created a COVID-19 dashboard. So this looks at, it includes a risk complications model that's kind of tailored to the integral care data and client population, so we can provide actionable data to the providers. It also allows us to track any presumptive positives that we've identified through different screening assessments that we launched at the start of COVID-19. And right now we're really focused on providing support and interventions to the community at large in Travis County, particularly citizens who are staying at guests at the city-run isolation facilities or who are housed at various hotels. For folks who still needed that in-person care, we made that happen for residential crisis, IDD, and our narcotic treatment program and homeless services. And to do that, we created different protocols to support health and safety along the way. We also, we're still making sure that folks experiencing homelessness have food to eat, helping people find jobs, safe places to live. For those that are isolated, making sure that they're still getting access to medical appointments, food banks, pharmacies. We sent nurses out into the community to make sure that folks are receiving their medications. We've also done a series of initiatives for staff to really support that healthcare, that self-care aspect. We've launched some Live Well, Lunch and Learn series to support staff well-being. And then like most other organizations, we're just continuing to kind of follow the CDC guidelines and just prepare for a tiered reopening whenever it's safe to do so. So for the impact on district program and funds that we've seen from COVID-19, we've experienced some net losses as a result of our COVID operations, but we're anticipating additional COVID funding to help mitigate any of the operational losses that we've seen. So far, we've received funding from the CARES Act. We also received funds from FEMA and SAMHSA to provide crisis counseling program supports and interventions. For the waiver support, we've switched most of our waiver-driven assessments to where they can be delivered over the telephone or via telemedicine. Typically at this point during the year, we'd be meeting close to 21 out of 21 measures. Right now, we're only meeting 14 out of 21 without any flexibilities allowed yet. So we're still kind of waiting on the allowable flexibilities that we'll see from HHSC and how that will impact our ability to achieve our goals. A lot of the measures that have been hit the hardest are any that require that face-to-face contact. So, a time-sensitive face-to-face follow-up after hospitalization within 7 or 30 days. We've seen a huge decrease in performance on that one since we've switched everything to telehealth. Anything requiring kind of vitals or measurements that are typically done face-to-face, we've seen a hit on those measures as well. Planning for the future, we're one of several providers around the state that are participating in the HHSC Best Practices Work Group. So this is supporting the evaluation of the district activities, also assisting with transition plan milestones and mechanisms for sustainability. So we're using this as well as looking at different alternative payment model arrangements with community partners to help support the district transition. Our leadership also works very closely with different trade associations, so National Council and Texas Council. And as a result, we've been meeting with federal legislators to kind of frame a proposal regarding severe mental illness, diagnosis-based eligibility for STAR Plus, as well as incorporating some sort of directed payment rate for the CCBHC model of care. So what we want the community to understand about our work now, we know this is a challenging time, not only for staff, but also for families and community members out there. We're also anticipating a demand for increased behavioral health services due to the impact of COVID-19 during this pandemic and post-pandemic. We're really anticipating a spike in that. So we're just encouraging folks to find the time and the space to support self-care, and reminding everyone that we have a 24/7 hotline that they can use to reach out to us anytime. But again, just really emphasizing health and wellness during this time and taking care of yourself, both for staff and our community members. And that's it.
Thanks, Brittany. I appreciate your update, and I know that the mental health impact of this is significant now and will continue to be, as you say. So thank you for your work. Finally, let's go to Kyle Landry with St. David's Healthcare for an update from them. Kyle?
Thank you, Katie. As Katie said, my name is Kyle Landry. I'm the COO at St. David's South Austin Medical Center. And yeah, as you can imagine, being a hospital provider in a pandemic, life has changed a little bit of how we can provide services in a safe and effective manner. But I wanted to start off by saying how proud I am of not only our teams, but everyone across St. David's Healthcare for what we've been able to do in this pandemic to continue to care for our community in the most seamless way possible. Looking at kind of what we've done in DY8 and our successes, our project is mostly focused around the maternal care in those areas. And so we've really kind of used the district kind of framework and the project that we selected to really improve our metrics in our women's services line, which has been a great improvement to our moms coming in here. How our organization responded to COVID-19, we had to rethink quickly because, when you have governor's orders coming down, City of Austin's orders, you need to make sure that you're doing things fast, but not also very thoughtful, so that you're not, making any step ups or anything like that. So we've had to really work on, making sure we can educate the community and the family and our family members who are coming here to the hospital about the safe and effective way to be into our hospital, but also really making sure that we're keeping our staff safe and all those who are caring for patients in this pandemic. So it's taking a lot of time to just focus on how we can continue to provide healthcare in a safe and effective manner underneath a global pandemic. Another thing that really kind of hit us recently, as a lot of other healthcare providers, as we talked about with telemedicine, has been our availability to provide that emotional support to patients that are coming into our hospitals when their families are not able to join because of visitor restrictions and things like that. That has been something that's not only been allowing our frontline workers to really rethink how they do care delivery, but also how do we communicate better with our family members who might not be able to visit their loved one while they're in the hospital. The expected impact of COVID-19 on district, again, from our side, our project was focused around the maternal care, and as a result, people are still having babies. even within the pandemic. And so we are making sure that we can provide people feeling safe before they're coming to the hospital, and also educating them on what we need to do to keep the family members safe once they're discharged from the hospital as well. You know, we're really kind of planning on our future district, our future given districts in COVID, is just really trying to make sure we keep all of our options open. And so I think we're continuing to watch what availability we have to continue to participate in the program and go forward. And then at the end, you know, what we most want the community to know is, just like all the other healthcare providers that spoke today, you know, we are continuing to be open, and we want to make sure people know that they need to continue to come to the hospital to seek the care that they need. Because at the end of the day, we have seen, you know, in the first shutdown, you know, people were holding off to receive care, and potentially too late, and then that was something that could have been affected. So we are providing healthcare in a safe and effective manner here at South Austin and across all St. David's healthcare, and we'll continue to do that with or without a pandemic in the future. Thank you, Katie, for letting me be able to speak today.
Thanks, Kyle, and thanks to all of our panelists. I mean, I heard a lot of themes from what you were saying, primarily that not only are you working to respond as effectively as you can, you're also continuing to provide the critical care that was needed before the pandemic and will be needed afterwards, and you're learning from this and learning how to continue improving care going forward. So much focus on telehealth, which I think, while is challenging, is also really exciting. The positive response from patients to that, I think, is also really encouraging about where we can go. I think Matthew mentioned this, like what the possibilities are with telehealth going forward. And just the commitment that you all are showing to serving underserved populations through all this is really evident, and I thank you very much for your work there. So let's move now to questions from the community. Carol, do we have any questions on the chat that we can review right at first?
No, we don't.
Okay. Well, then let's open it up. If you would like to ask a question of our panelists or of me, you can either unmute your line and say so, or you could use the raise your hand function on the participant panel, whatever works for you. And we will, if you're on video and you ask a question, if you want to turn your video on, we can see your face, that would be great. Providers, do you all have questions for each other?
This is Ann. Can you hear me?
Yes. Hi, Ann.
Yeah. I just have more of a comment. I think I was assured by the theme of most every presenter's presentation of the challenges and the impact on patients, and you know, having to pivot so quickly in so many different ways for so many different reasons because of COVID, whether it was telehealth or, you know, trying to manage a hospital during a pandemic and all the challenges associated with that. So I just wanted to place a comment. Sometimes you think you're in an island and you're doing the best you can and you think you're doing it right. So this was reassuring, I think, that we all approached it in some similar ways to try to navigate through a really unprecedented time.
Agreed. While we are so focused on our individual responses, it can be easy to lose sight that all of us are really in this together, which I know the pandemic itself has pointed out in so many very clear ways what kind of impact we all have on each other. So appreciate your comment, and yeah, we're here together working towards the same goals. Other questions or comments? Well, with that, if there are none, then we can give you all back a half hour of your day, or 20 minutes. I really appreciate everyone coming on and listening. Very much appreciate our providers for your updates and all that you're continuing to do. Definitely check texasrhp7.org for the slides from this and a recording of today's webinar. And keep in touch with me and with Carol Saucedo on the Anchor team. Our contact information is also on that website. And we'll be in touch as more movement happens with any funding proposals or changes to the DSRIP program. We'll keep you all updated there. Final reminder that if you haven't signed in by typing your name and organization into the chat or sending me a quick email letting me know you're here, please do, so we have a record of who attended. And thank you again. I appreciate your time and have a great rest of your day. Bye-bye.